Hi, I'm Mina Malik Hussain. You're watching The Coffee Table, and today we have a very important conversation and a wonderful show lined up with two excellent professionals. But please consider this a trigger warning. Today's show is about eating disorders. And if you feel like this is the kind of content that might be upsetting for you or for anybody watching, then we do suggest that you not watch and you change the channel. For everybody else, welcome to the show. We are delighted to be welcoming today two experts on eating disorders. We have a nutritionist and a psychiatrist, both coming to us from Islamabad, and we are really excited to be able to unpack eating disorders and to talk about what symptoms are, whether you think, how to recognize whether you or a loved one has that, and the kind of, the cultural and familiar systems from which these disorders do emerge. So it's a serious conversation, but it's also one that is really important to have, and we really feel like the more we talk about these things, there's nothing to be ashamed about, and this is how we are able to expand conversations so that we can help each other live a happy and healthy life. And I'm so happy to be welcoming today on the show Dr. Rezzan Khan, who is a consultant nutritionist who practices at Shifa International Hospital in Islamabad. She has also got a PhD in nutrition from the Iowa State and Kansas State University in the United States. And also joining us is Dr. Mehboob Yaqub, who is a consultant psychiatrist also at Shifa International. Hospital full of these wonderful doctors. And is, amongst other many wonderful things, is an accredited practitioner of EMDR therapy. Welcome to the show, doctors. So, Dr. Mehboob, I'd like to begin with you. And as I like to say on the show, like, begin at the beginning. So how do we classify an eating disorder? Like, what does it mean? What is an eating disorder?
Essentially, it's a disordered eating or extremely abnormal eating patterns.
Right.
So there's a big umbrella term and all the different types of these eating disorders come under that umbrella. Mm-hmm. So generally, we call them eating disorders. Right. Depending on how they present, we can classify them and try to differentiate them from each other. And the effort is only to really identify the underlying cause so that the appropriate treatment can be offered accordingly. And how serious a disorder is, how much of physical intervention is needed, and how much of psychiatric and psychological intervention is needed. That's exactly why we try to differentiate these different type of eating disorders. But the most common two disorders are anorexia nervosa and bulimia nervosa, and probably many people have heard about it. Media has projected quite significantly about it over the last several decades. So yeah, and if you want me to go to more details about these disorders, I certainly can, unless you want to talk about something else now.
No, we will, anon. So when you said an eating disorder is a deviation from a normal eating pattern, so what is normal eating? How do we classify that?
It's not to define the normal eating pattern. It's more so extremely abnormal eating habits. That's where the differentiation is, rather than differentiating from something abnormal. Overall, we all have different eating habits.
Right.
So all these different eating habits, sometimes we don't like a few things, sometimes we avoid eating some particular foods. That's an eating pattern, that's an eating habit.
Yes.
But when such an eating habit goes to an extent that it starts harming our health, physical as well as psychological, then it becomes abnormal, and then it becomes a disorder.
Oh, okay. So we're saying, like, for example, in a very sort of layman's terms, it's very normal to not like, I don't know, bhindi, for example, and you just don't like to eat it. But if it becomes a kind of an aversion that becomes something that really interferes with your normal life, then that's when it's begun to kind of veer into territory that is slightly alarming.
Something similar to when people have obsessive compulsive disorder. I mention it here because there is a relationship there. They can coexist.
Yes.
Many people have intrusive thoughts. They have superstitious thoughts. But when these superstitious thoughts reach an extent, when that starts disabling us and stops us from carrying out our daily routines, then it becomes a disorder. Similarly, in the eating disorders, there can be variable, some very not so routine kind of eating patterns, eating habits. But when they get to the extent where they start having a very obvious harm on our health, physical as well as psychological, then it's a disorder and then it needs to be treated.
Right. No, it's really interesting, and I'm glad that you brought up obsessive thoughts as well, and I do want to cycle back to that. But before we do, hi, Dr. Rezzan, can you hear me?
Yes, I can hear you.
Hey, welcome to the show. So from what I understand so far, when we're looking at an eating disorder, we're looking at ways that we control our intake of food. And some people do it by restricting food, and some eating disorders manifest as an excess of food. But in either case, it does come down to kind of malnourishment for the body, isn't correct?
That's what it is in eating disorders. And then in this eating disorder, is Dr. Mehboob was talking that anorexia nervosa and bulimia nervosa is the most common ones. But they have the similarities. They both want to be very slim, unpredictably underweight. Sometimes they lose their weight, 85% of the ideal body weight. Can you imagine? It's just the bone weight. And then still they think that they are fat. That fatness is in their mind. So, but most of the time they are happy and they don't want to change it. So it is up to us how to deal with these people. And usually they want to change, but because of the genetical reasons or environmental reasons, biological, physiological, and all those things affect, and then they get into the trap. In the anorexia nervosa, we can treat them just like protein, energy, malnutrition. So they almost lose all the fat, all the lean body mass, and then it affects their health.
Yes.
Because they don't get enough calories, they don't get enough nutrients, and it is amazing that you can see that even their cholesterol and carotenoids are increasing. And you say, where do they come from? Because when they do such things, they put their body under stress, and it affects the liver functions, fat functions, and then there is no bile to take them out. So they just accumulate in the body. So it can cause further problems too. And when it comes to bulimia, then, for example, anorexic patients, they usually eat about 500, maximum to 800 calories a day, which is when you compare it with the minimum 1,600 to 2,500 calories. So it is so little. And in bulimic patients, again, they are centered around reducing weight and then becoming very slim, but when they eat sometimes 20,000 calories. 5,000 calories in a restricted time. Because it's just like they are in the pressure cooker. They just keep on restricting themselves, and then when they see something that it's appalling them, they just want to jump on it, and then they lose their senses. They keep on eating in a short time. Then what do? They feel guilty. They go and purge it out. So these are the things you can differentiate between the anorexic and bulimic patients too.
Yes.
And actually all these things affect the person from hair to toe. When you look at the anorexic patient, for example, anorexic patients, they are always underweight. And bulimic patients, they are not all the time underweight.
Yes.
They are sometimes normal, even sometimes they are obese, because they go on the yo-yos.
Yeah.
And then when they come out, they think that they are throwing out everything, but not. When we are calculating the caloric intake, 50% of the calories stays with them. Only 50% is they come out.
Which is why they don't look malnourished, sort of visibly malnourished, which probably makes it tricky for people around them to identify that they do have an eating disorder. And Dr. Mehboob, do you see that in patients? Yeah, that's what I want to know. So actually what I'm asking, what I'm curious about is that in your practice, do you have patients coming to you ostensibly for one thing, but they've actually also got an eating disorder, which their families may not be aware of, or they themselves might not be aware of? Is it possible to have an eating disorder and not know you have it?
It is very common. It is very common. For example, more so in our clinics, in psychiatric outpatient clinics, when it's bulimia nervosa, nobody knows. Patients may know they have been trying to control their weight, but they may not be aware what kind of trap they have set for themselves. What if they have really developed an eating disorder, but they are just there for years, for months, they have just been trying to control their weight. And in that bulimia, as Dr. Rezzan said, they may be trying to restrict themselves from eating and then eventually bursting and having a big, huge meal. So there are other psychological, psychiatric conditions they can present with, and during those assessments, we can come up with these strange or abnormal eating patterns. That's to do with the bulimia. For anorexia, it's usually quite obvious. They are thin, lean, their parents are banging on their head, they are not eating, do something about it. What's going on with a child? Mostly it's a girl. I think 10 times more common in females, so young teenage girls brought to the clinics by their parents and really trying to force them to eat, which they have not been. So yes, it's mostly people don't know what's going on, especially in terms of bulimia nervosa, but anorexia nervosa is fairly common, and it's quite obvious as well. You can't miss it.
Now, when we're talking bulimia, from what I understand, it sounds like a lot of times bulimics binge eat. But binge eating itself is also an eating disorder. So is there a difference between those two?
Yeah. All these eating disorders, they have very strict criteria. And that's on the basis of these strict criteria, we diagnose people having these conditions as well as other mental health conditions. If they don't fit into anything like just the bulimia nervosa, and they have just binge eating pattern, and they are not as restricted as they would be in bulimia nervosa otherwise, in terms of calorie intake, then we just call it binge eating disorder. But the point is, as I at the very beginning said, that it's an umbrella term. So not necessarily fitting them into a box that this is that eating disorder, this is that, because one diagnosis can change into other over a period of time and then go back to the first one as well.
Okay.
So eating disorder as an umbrella term, and then having a specific identification at a particular time, what kind of extreme eating pattern they are presenting with. So binge eating disorder can later on go towards bulimia nervosa. It may have started as bulimia nervosa and then moved on or got down on intensity down to just binge eating disorder. So yeah, it varies. There's no rule of thumb in terms of differentiating them.
Wow, so that sounds like when we are looking at treatments and treating an eating disorder, then one has to be quite vigilant, because you can be moving from one to the other, like you said, Dr. Mehboob. It seems like there is a kind of fluidity to that. And you also mentioned how sometimes these are also these also sort of emerge from obsessive behaviors as well. So there can be several underlying things sort of coming together to create a situation in which an eating disorder is one of those situations.
One common factor in, let's say, if it's bulimia nervosa, and we were talking about how it presents, is they are preoccupied with food. And they are trying to restrict themselves despite having that preoccupation with food. So that intrusive thoughts is very common to the obsessive compulsive disorder, where people can be obsessed, preoccupied about something else. And then as a result, they have a compulsion. In bulimia nervosa, they are preoccupied with food. They are restricting their food intake, they have heightened anxiety, and at the end they cannot resist it, and more like compulsively they have a big meal, a huge meal. And that does not happen, let's say, after every few days. It may be happening every 24 hours. They restrict for several hours, and at the end of the day, they'd say, that's it, I can't take it, And that's a huge, big meal that they end up taking as a binge.
No, but I think this has all been really, really interesting. We're going to take a very quick break and come back to this very important conversation. Stay with us. Welcome back to the coffee table. We're having a very, very important conversation about eating disorders with nutritionist Dr. Rezzan Khan and psychiatrist Dr. Mehboob Yaqub. Again, I would like to reiterate this trigger warning that we are talking about eating disorders, and if this is the kind of content that may be upsetting for anybody viewing, please change the channel. So Dr. Rezzan, before the break, we were talking about how a lot of eating disorders come from a sort of compulsive approach to food. And from what I understand, a lot of eating disorders manifest in girls and boys, young men and women, in adolescence. So why do you think that is?
Because when they are growing up, during puberty, their body shape is changing.
Yes.
And they usually complain, especially the girls, oh, my breasts are coming out, my tummy is getting out, my thighs are so big, although they are not, but this is the normal physiological changes.
Yes.
And then they don't realize it, and then they want to just finish all those things, and then they want to get that girlish look.
Yes.
And then same thing goes with the boys too. And then, of course, that is in their premises. And then the other thing, they keep on watching the movies, and then they see those models, and then zero size and everything, and they want to be like that. Or they just get stressed. Maybe they just want to punish their families. There are so many reasons to be like that. And then they can just reach, and then they get their anger on the food restriction.
Yeah.
With this way, they want to maintain their very little fat in their body, and if there is no fat, they'll be more happy, and then they do everything for it. Yeah. But it really harms the people. And I had one patient with the bulimia, and then she was using the fork for inducing the purging. And one day she swallowed that. And then she came to Shifa, and then there was a major operation. And even I used to feed her with the parenteral nutrition through IV, and then I used to feed with the intestinal tubes and everything. So it can go that extreme too. And I had another case like that, and then after eating, they feeling guilty, and then getting all the laxatives, diuretics, and all those things. So when we are really doing the assessment, we have to check everything, what medications they are taking. Maybe you'll be coming to that later on. And
is it also true that in adolescence, like you mentioned, it's just normal for the body to start changing shape in girls and boys, but clearly there is more pressure on girls because more girls, and like Dr. Mehboob said, 10 times more girls, 10 times as many girls have eating disorders than boys. So clearly there is a kind of a social and cultural reason why girls are facing more pressure to look a certain way than boys. Does your metabolism also change in adolescence?
Metabolism is usually faster during adolescence.
Okay.
And then, of course, when the age goes on, metabolism will slow down. But usually the thyroid hormones, they can adjust to that.
Yeah.
Our metabolism. So I don't think it is the thing. I think mainly the cultural and environmental and then the social factors are affecting that.
Yes.
Of course, the genetics are there, but with the genetics, it can just take the part about 30% of the reason, and 70% you can just change it with the environmental factors, and you should explain them.
No, I think that's important. That's very important because a lot of times people blame a lot of things on genetics, but like you said, it's only 30% of the issue, and 70% is about a lot of other social, cultural, psychological things as well. So, Dr. Mehboob, generally, What is the sort of psychic relationship that we have with food? Because clearly there's a link here between how we deal with the situation and how we feel like we are in control of things when we can, and a sense of sort of, if you can control your food, even if you can't control anything else around you, then your food intake is something that you can control. And like Dr. Rezzan said, a lot of adolescents, cope with anger or frustration by then restricting calories, for example.
Yeah. Well, when we are born, gradually, natural instincts are we get some pleasure out of food. Right, so there is satisfaction after food, and there are proper biochemical mechanisms in brain, satiety centers. How we develop this hatred, let's say, for example, let me use the word, although it's not across the board, but how we develop this hatred as we grow up is many a time a reaction to whatever else is happening around us. Now, this is a very, very vast subject. We cannot really pinpoint on simply everything, and different people, different individuals may present with a whole different set of difficulties. But the basic theme is the same in the end. And that you just mentioned is at least the only aspect they can exercise some control over their life, and that may be how they control their food intake. But that is not the whole story.
Yes.
It's not just the control. It can be the peer pressure. The rest remaining friends, they want to remain in a particular physique, and you are under that pressure that you want to be looking like that. If you don't, they may start bullying you. If you are overweight, if you may look slightly overweight, people bully you. And this is so common, people don't even consider it bullying. This is so common in our schools. People talk about other kids' nose, their eyes, their appearance, their big face, their fat tummy, their height, their weight. And even, unfortunately, this is so unfortunate, even parents do that to their children.
Yes, absolutely.
Even families do that to their children. Exactly. And that's so hurting, that's so traumatic for a child. You don't know what that child is going through.
Yeah.
And then sometimes it may not just be an eating-related issue at all. The family may be so controlling overall. Family, mom, the dad, they want them to be absolutely perfect with their eating habits. They want them to eat this, that, those things. They want them to have fruits. They want them to have no chocolates whatsoever. And the dinner table is usually a very stressful environment. And sometimes it simply may be a reaction to it. Eventually, when they get control over it, they have grown up to an extent that nobody can force them, nobody can hold them from their neck and ask them to eat. As a child, maybe now they can react, so they react. So it's variable. You get a huge number of different scenarios. You just have to find out what is happening. And eating disorder is just the tip of the iceberg.
Really?
There is a lot happening. It's not just the eating disorder we have to eventually treat. There are a lot of other things. There may be sexual abuse going on somewhere. There may be any other, bullying is a kind of abuse anyway, but there may be additional sexual abuse going on. So what are these kids reacting to? That is what we need to find out, and that's what we need to treat. Without treating the underlying cause, we cannot get rid of the eating disorder or abnormal disordered eating. So it's the underlying cause. That's why psychiatry, psychology, or even the physicians, they all need to sometimes sit together. It's a multidisciplinary intervention.
No, I think that is so crucial, and especially the point that you raised, Dr. Mehboob, about how when children are younger, you can force them to eat. And I think that this happens in so many families where, you're told that you can't leave the table unless you finish the food on your plate. And you can do that with a 6-year-old or a 7-year-old, even a 10-year-old. But when you have an adolescent, you can't necessarily pin down a 14 or a 15-year-old and say, you can't leave the table, because then that's where they have enough wherewithal to sort of say, no, I don't want to do this. But that happens in so many families. And I think that in a lot of brown families and Desi families, this happens where you're told that wasting food food is bad, and that a lot of parents have anxieties about their children eating enough. So Dr. Rezzan, as a nutritionist, how can parents who are concerned about healthy eating and wanting their children to eat healthy and to have a kind of, sort of a healthy lifestyle or a healthy approach to eating, what can families do to foster that? And what techniques can they use to be able to understand their children's eating habits as well, so that they don't feel like they're being coerced or forced?
I think the parents themselves should set a good example at the table. Okay, when they are asking the food, they should try to provide from all the food groups in a very presentable way.
Yeah.
And they shouldn't really push the children, you have to eat this salad and chapati.
Yeah.
Maybe they don't want to eat that, but when they go out, they are eating those burgers, shawarmas, and such things. And they can make something similar to that sometimes, and then they can introduce it to children, but they have to set good example. For example, in Pakistan, nobody eats salads.
No,
very few families.
Yeah.
If you don't put it at the table, why they will eat? And these children, when they eat, they are anorexic or bulimic, and then they usually go for the vegetables.
Right.
They go for the salads and such things, and they try to avoid all the carbohydrates, fat. They think they are the bad one, and they start discriminating the food. So this thing, providing it properly at the table, and this is the century. Not everybody comes home at the same time. If the child wants to eat in front of the TV, so nothing is wrong with it. I'm sure in most of the families, that's the practice now. Everybody is working out. So they shouldn't be very strict and then running after them. Especially when we are talking with the adolescents, we should give them some space.
No, I think that's very crucial, and that is something that really doesn't happen a lot. But then, how does one sort of address these anxieties? Because do you feel like this is sort of endemic to families also, and especially in joint families, for example, whereas maybe a mom is not pressurizing their teenager to eat if they're not hungry, but then you might have a relative, a grandparent or an aunt or an uncle saying that, "Oh, you're not feeding the child," because this also happens quite often.
That's very common in the common. Yeah, but I don't know how those family members can get together to eat. Because I think that's the only time they get together during the iftar time and maybe sahri time. So they shouldn't really push the children, and they should make sure that they can eat anything, but they should make them understand about the food groups. For example, if they want him to eat the fruit, so if he doesn't want to eat apple, he can eat banana, he can eat apricots. Or if he doesn't want to have the chapati, they can eat rice, potatoes, slice of bread. As long as they get enough nutrients from all the food groups, I think we shouldn't be pressurizing them. And most of the tables and most of the kitchens, all these things are available too. I think we need to educate the parents first, then they can educate their children. And I get many children here, like this adolescents and such things. And can you imagine some of them really under psychiatric medications at this age?
Wow.
This is sometimes, this is sometimes because of the pressure, either inner pressure or from the outside pressure. But this is the thing. And there is a very good experiment. They were doing it. And I think, I don't know in which year, but I read it, and then they fed they gave these two mouse to the mother, and one of them, he just kept on licking the little baby, and then the other one just ignored. And then they checked the hypothalamus and stress level and eating and everything later on. They find out that who was getting that loss of affection from the mother had a less stress hormone from hypothalamus. And then he was just doing very regular normal eating and normal behavior. The other was not doing that. So such things are experimental for the animals, but there are so many reasons and experiments on the too.
Yeah, so and to kind of expand that, it really does mean that a lot of times kids are reacting to things because, you know, in the case of the little mice, it was that they were receiving affection from their mom. And I would kind of expand that to say that a loving family environment makes things so much better for everybody in them. We're going to take a very quick break. On that note, we'll be back in a minute. Stay with us. Welcome back to the coffee table. We've been having a fascinating conversation with Dr. Rezzan Khan, who's a nutritionist, and Dr. Mehboob Yaqub, who is a psychiatrist, both at Shifa International, and we've been talking about eating disorders. And once more, I would like to reiterate my trigger warning that if this content is disturbing for anybody watching, then please do not continue. Right, before the break, we were talking about family patterns and about family dynamics, and I think that that is really crucial. But Dr. Mehboob, if we can kind of dial it back a little, I know that a lot of times we equate depression with an eating disorder, but is there always a connection between that? A lot of times people with depression don't necessarily have eating disorders, and people with eating disorders aren't necessarily depressed. Like, it's not an either or.
Generally, how I observe things in my clinic, with depression, mostly you see reduction in your appetite. But
right.
That's not on the same principles as we see in eating disorder.
Yes.
It's a genuine symptom of depression. And sometimes in atypical depression, we get some increased appetite. Again, the underlying principle is different from eating disorder. So from that, this is my observation, and I haven't come across any research so far which says that with depression can lead to eating disorder.
Right.
However, the eating disorders do lead to depression. They do lead to anxiety.
Okay. Right.
Right, and the mechanism can be stress. Stress can be a trigger. It can be plainly because of the eating disorder that they develop a depression, or it can be some other underlying stressful factors which have led to eating disorder and now are also leading to a depressive illness. But they are just triggers. The illnesses like depression, they have triggers. They have predisposing factors and stressful factors that just make them appear in front of you. So from eating disorder to depression, it is more frequently used.
Right. Now, I know a lot of times when we look at eating disorders, and because more girls and more women, young women suffer from eating disorders, but men do too. And I feel like that's sort of an aspect of the conversation that we don't really talk about. So how does the sort of eating anxiety manifest in the men that come to see you?
Changing. Let me give you, it's not a good news, but it is changing. Recent evidence suggests that more and more men are now developing eating disorders.
Right, but that's not good, but okay.
It's not, certainly not good. Equality, but again, we don't want to see any of them, not males, not females, to be suffering from eating disorder. It's not a pleasant thing.
No.
But again, the underlying principles are the appearance, the peer pressure. They want to appear smart, so-called smart, the so-called standards that our international cultural media we have all set. We don't want to see a fat, I'm sorry to pardon my word, please, but this is how people explain it. Nobody wants to see an overweight, probably a milder word, an overweight person to do an ad for a company, for, let's say, a perfume, let's say for clothing. They don't want to bring any, even this day. You want to go through your ads, whatever is running on the TV, you will see every single person is appearing to be smart, muscular, and ladies, they are very thin. That is what is causing the problem in males as well as in females. Yeah. Social acceptance they want to go with. Yeah. So yeah, it's no different in males, it's no different in females.
So if, for example, you have a young man in your life who might be eating all right, but is obsessively exercising, is that something to be worried about?
It is, because sometimes it's just exercising excessive activity, which can lead to this anorexia kind of situation. So even within the anorexia nervosa, we have two types. One is this binge, where sometimes they binge purge as well. They eat all right, but they excessively make themselves vomit. They may take such drugs that they pass urine frequently, they go to the toilet frequently, and they exercise as well. So sometimes it's not just the food restriction. Food intake may be just about the borderline, but the excessive exercise may be just a way of keeping their weight down. And that's related to what circumstances they are in. They may not be in such an environment where they can control their calorie intake so strongly, but they go to the other side and they do excessive exercise, and then that's how they reduce their weight.
So that's also something to watch out for. So Dr. Rezzan, I know that a lot of people also view food with their moods. So apparently there is a study that says that a lot of angry people tend to eat more sugar because it calms them down temporarily. So if one is aware of, or you know how people comfort eat as well, or people respond to trauma by eating, or when they're sad they eat. So how can we kind of break that pattern? So nutritionally, how can we sort of develop a healthier approach to the kinds of foods that we turn to when we feel like we need comfort?
Okay, when the patients come here, either they eat wrong things and then, or they give a big gap between the meals and then they keep on nibbling. So if they eat so much sugary things, it is going to trigger the insulin level and then it's going to push the sugar into the cells, and then the person will feel more hungry and then they will just keep on eating again. And this is another thing. And then we have to really educate them to structure their meal pattern. So if they get it for the proper breakfast, lunch, dinner, and maybe proper snacks with the low glycemic index, and then with the protein, fat, and everything, and then I make sure that they are not going to really increase their weight, and within this you can teach. So the main thing is educating them for the food exchange list. If they don't want to eat that, what they should eat, and we have to educate them for reading the nutrition fact of the ready-made foods, and we can structure their exercise level. So all these things have to structure. Otherwise, it's not going to be endless. It's going to be endless. Just eating sugar.
Because you can't use, if you use food as a crutch for your emotions or dealing with feelings, then food is always going to be problematic. There's always going to be a problematic relationship between you and what you're eating.
Maybe they can have some nuts rather than chips.
Yes.
They can have some fruit, or they can have some diluted fruit juices rather than putting 8 oranges in one glass of. One glass. I can use one orange and then dilute it with the water.
Yes, those are very good ideas. To sort of exchange those and sort of just make swaps wherever possible, so that even if you are kind of sort of comfort eating, then you're not eating something that's going to sort of ultimately cause an insulin crash, for example. But as a parent, Dr. Mehboob, I am curious, what are the kind of questions one can ask people in one's life if you are afraid that something is not quite right with how they are eating or exercising, and you're sort of one feel, like you have a gut feeling that this is not okay? Because there is obviously a difference between a child who skips lunch or eats late, and there's a difference between that and a child who is most certainly not doing this in a casual way.
Well, there is no secret. When we are trained as doctors, we are taught to take extensive histories. Even if it may not appear relevant, don't be tunnel vision, take all the detailed history, starting from early childhood, developmental history, how kids used to have friends, how they communicated, how they eat, what are their eating habits. And that's the way you cannot miss anything. It will straight away be in front of you. So as I said, it's not a secret. It's just a habit as clinicians, as doctors that we develop. We have to develop sometimes, and some people forget those habits. But we have to be extensive in our history taking so that we don't miss out on anything.
No, quite right. But as a parent, for example, or if somebody, you're in a family situation where you feel like, this individual doesn't eat a lot, or seems to eat, or seems to be in the bathroom a lot, and you kind of feel like something is wrong. What should a layperson, how can one kind of gauge the situation is bad enough that you need to seek professional help? How would you know that?
You will just have to speak to the kid, first of all. And that is a problem in many families. People don't communicate. People cannot speak to their kids. Kids cannot ask questions from their parents. So communication is the key. If you are suspicious, so instead of keeping that suspicion within yourself, you just need to sit together with your child and ask them that we are worried these days about you. You're spending way too much time, let's say, in the toilet. That sometimes may appear rude as well, but without communicating it, without asking them, you cannot get anywhere. Similarly, with regards to their eating patterns, you have to just communicate with them. So please be open, please be calm. If you are angry while communicating, it's not going to work. It is not going to come out. There may be instances where you have to bring up your tone a bit to get something out of your child. But that way you will know that without that you're not going to get anything. But that's rare. Most of the times you have to build this trust. You have to build this relationship where you can communicate. And if you are worried about something in your child, you should be able to ask. And they should be able to communicate it back to you without any fear. So that you should be on the same side rather than you working against them. You being going in an entirely opposite direction. You should be working together. You should be saying, well, we think there's something wrong. Let's work together. And that's the word, that's the buzzword. Let's work together.
That's very important, actually. And, we're talking about a sort of an adult and a child relationship, but I'm sure that would be true for any adult any adult as well, that you need to kind of gradually approach it and then keep at it where they feel, and you build trust where they feel like they're in a position where they can be honest with you. So, if at first you don't succeed, keep trying and keep sort of trying to create a safe space for somebody to be able to confide in you so that you can work together and get the help that you need. Thank you so much, Dr. Mehboob and Dr. Rezzan, for being with us today and for this wonderful conversation that I'm so, so happy that we have had. Thank you guys for watching. I hope that this has been as informative and helpful as it has been for me. I've learned so much. If you're watching this on YouTube, don't forget to like and subscribe, and we will see you next time on The Coffee Table. Bye now.